Dr. Simba Fidel. I'm a resident in plastic surgery.
Good morning. I'm Victor Mukamita, I'm a first year resident in plastic surgery, and we're delighted to be your host for today's symposium.
Nice. So we would like to welcome you all and acknowledge the presence of different parties amongst us. We'd like to acknowledge the presence of faculty from UR, School of Medicine and Health Sciences, also Ministry of Health and HRH Secretariat, Operation Smile International, Rwanda, and various stakeholders, including the Rwanda Surgical Society, Rwanda's Society of Anesthesia, and the National Council of Nurses and Midwives, including also surgical trainees and medical students.
Without forgetting people who are attending virtually, so a few of them, we have Professor Amanda Osman, we have Professor Robert Miguel, we have Professor Gela Tefera, and we also have Edward Gwande. And for those of you who were not mentioned, you're also welcome for this today's symposium.
Nice. So today, this is a beautiful day. I hope you all have had a nice rest, and those who had to travel this morning, we welcome you all. We're happy you're all here. So this day, we have a theme we're going to talk about and different objectives. So I would like Dr. Victoire to take us through the theme and specific objectives. Thank you.
Thank you so much, Simba. So today's theme is Rwanda NSOP implementation. And for those of you guys who are not familiar with NSOP, it's National Surgical Obstetrics and Anesthesia Plan. And we're going to be talking about the role of plastic and reconstructive surgery capacity building in healthcare system strengthening. So this symposium have different specific objectives, but to talk few of them, we're going to focus on, we're going to look for the, to highlight the role of Rwanda plastic surgery capacity building program in achieving NSOP targets. We also focus on the brainstorming on how to keep track and monitoring progress in implementing Rwanda's NSOP for specialty development, to evaluate progress so far made in the implementation of Rwanda NSOP. Without taking much of the time, Dr. Simba, who are we going to have first?
So the first speaker will be giving us welcome remarks, and would like to welcome Mr. Andrew Karima, the country manager of Operation Smile and representative in Rwanda. Thank you.
Thank you so much. This is a beautiful day indeed, and I would like to start by greeting you both in Kinyarwanda and English. Good morning. Muraho neza, murakaza neza in this beautiful and great activity. I would call it an activity because it's going to generate a pathway of guiding us on moving forward with the NSOP. Without taking much time, I'm Karima Andrew, and I'm the country representative of Operation Smile, and I'm honored to welcome you to this noble initiative. I will borrow from my leadership comments and statements, and I'll take you a little bit to the background of Operation Smile. Operation Smile was founded in 1982 by Billy by Bill and Kathy Maggie, and it was founded on a simple, let me call it a simple initiative of a child who took us to the field to look at the need and magnitude of surgical need. Operation Smile is a global non-profit specializing in expert cleft surgery and care. We provide medical expertise, research, and care through our dedicated staff, medical and student volunteers, and of course, several other partners, alongside local governments and non-profit and health systems. And this is supported by our generous donors. We believe that all children deserve access to high health care through our work. We have provided free life-changing cleft care surgeries. And of course, in building into the health systems, we have done quite a lot, and it's self-explanatory and it's visible. The care that we have provided is estimated to around 300,000 patients, but more is needed in the countries where we work, and it's estimated to 5 billion people with cleft care need. So as our top leadership puts it, the child with a cleft took us back to the community to show us the need and get us to the attention to health system, and that is by Dr. Bill Maggie, the co-founder and CEO of Operation Smile. And we have worked for around 40 years, working towards reducing the backlog of cleft patients. And Operation Smile now is entering a new era of global network deriving access to high quality care and providing safe cleft which requires strengthening local systems. And that's exactly what we're looking at today. This leads to a greater access to health care for everyone in the community. So our the communities, it's our center of attraction, if I may put it. Over the next decade, we will continue to provide world-class surgery, cleft surgery and care in more than 30 countries. We are looking at investing in 40 hospitals, and I think Rwanda has a huge portion of these hospitals where we want to invest. And that is to create programs and increase access to safe care for 1 million patients. We have and are walking this journey with various partners and building it from strong collaborations and partnerships. Our MC said it clearly that we have different representatives of different entities, and that is the showcasing of partnership and collaboration, which Operation Smile would never cease to appreciate. This is the second annual Plastic and Reconstructive Surgery Symposium, under the theme that our MC has mentioned. And Operation Smile is honored and pleased to welcome you to this noble initiative. As we mentioned, we are not alone in this journey. We are with several partners and stakeholders. And at this juncture, I would wish to welcome, and I'm privileged to have that chance to welcome our guest of honor, Dr. Vincent Sanganwa, Head of Teaching, Teaching Coordination and Quality Insurance Department at HRH Secretariat. Dr. Vincent, we are honored to have you here to open this symposium officially. Welcome.
Good morning, everyone. Dear professors, country director, doctors, students here in this room, and others, and all protocol observed. I'm really honored to be here and to represent the Ministry of Health in this second annual symposium on plastic and reconstructive surgery. And participate in this discussion. Well, we can be inspired and have new ideas for advancing the country development, especially in the health sector. It's a vision 2050. Rwanda aims higher toward its development agenda. Rwanda plans to reach at least the lower level of high-income countries through reaching the middle-income country at 2030. This development agenda is implemented by the population of Rwanda and for its development partners. The government of Rwanda considers that the population as a critical and important resources for country development. In this development journey, human resource for health is considered as an ingredient and important input for population development. Not only it's seen as service providers, but also as a precursor of economic development. This population have to be kept healthy so that they can produce and contribute to economic development of the country. This population, HRH is considered as the input which has an economic return, and this way is seen as human capital. It's human capital development, which is crystallized in Rwanda we want by 2050. It's crystallized in the vision 2050 and also in the health sector strategic plan, being in 3 ones we have already implemented and evaluated, but the ongoing one, which is health sector strategic plan, the 4th health strategic plan, but also in national strategy for health professional development 2030 that we all know and we participate in its development, but also in national strategy of obstetric and anesthesia surgery plan. Surgery is the surgery including the plastic and the reconstructive surgery is a big component of national surgical obstetric and NSOAP, and also national strategy for health professional development. To achieve these ambitious targets, the government of Rwanda understands that all stakeholders have an important role to play. Here we mean that the government of Rwanda and its agencies, such as the University of Rwanda, Ministry of Health, HLH Secretariat, but also its population, and also has professional societies and the partners in its development, including Operation Smile. It is in this regard that the Ministry of Health welcome Operation Smile and recognize its contribution in NSOAP implementation. We know that it has been beside the Ministry of Health by mission of service provision, but currently involved in the teaching and especially in surgery department, especially in plastic and reconstructive health. The Ministry of Health, through Human Resource for Health and the University of Rwanda, developed the curriculum which started to be implemented, and students are here present. Not only we count on our partners and our national effort, but also we want to be taught how, I don't know what I can say in English, but if to take a fish, not to eat a fish, but to do what? To learn fish. How we fish, for fishing. So I know that the Operation Smile have been coming in Rwanda for small missions and operating our patients. But it's good that he has taken another step of being beside the government of Rwanda, especially with the University of Rwanda, to participate in the teaching. This is a very big milestone that is well welcomed and encouraged by the government of Rwanda. In this regard, I would want to open officially the second annual plastic and reconstructive surgery symposium, where we can discuss the way forward and put the new milestones, where we can implement it together and evaluate together, so that we can be we can evaluate and we can see well the target we are reaching together. So it is in this note that on behalf of the Ministry of Health, we declare this symposium, second symposium of plastic and reconstructive surgery, opened. Thank you.
Thank you very much, Dr. Bensa, for the opening remarks. So the next speaker is going to talk about an So as a brief introduction of the speaker, um, he's an associate professor in surgery and a senior consultant in general surgery and plastic surgery. He's the head of Department of Surgery and also the director of NIHR Research Hub on Global Surgery. I would like to welcome Professor Hirenganya Foster for the next session. Thank you very much.
Good morning, everyone. Thank you, Simba, for introducing me. So I'm going to talk a little bit about the NSOP Rwanda. And the following slides, we will see how it has been developed and the targets that we have been assigned to meet for in the next 2 years, because it's supposed to be reached at 24. For the colleagues who are online and those who don't know Rwanda, Rwanda is a beautiful country somewhere in Africa, in Central East Africa, and we are very small, so many people cannot see us, but we are there. We do have a lot to offer, but we also can come and join and visit. We do have beautiful country, beautiful parks. The most famous is the gorillas. So please come and pay us a visit. But what we have most important is our people. And as the representative of the Ministry of Health was mentioning, it's a huge capital that we want to develop. And we ask all our thinking about putting people first and develop them. We, as a health sector, we are organized that way. From the bottom, we have the community, and on top, we have university hospitals, where many of us are coming from. But we try to link and to connect and to develop the whole system as one unit. As you see, our health system is trying to integrate the educational component and the patient care component. So we think that in the few years to come, each hospital will be able to teach and train, to teach and treat. So that's the new orientation. Talking to NSOP, this is a strategic document which was developed a few years ago. Actually, it has been launched back in 2018. And when you visit the Ministry of Health website, so you see many strategic documents. So among them, that one highlighted in yellow is the NSOP. So those who want to go and have a look on it and read it, understand what it's talking about, they can be finding it on the website of the Ministry of Health under the strategic document section. The methodology to develop this was a collaborative methodology where different stakeholders were put together, brainstorm, and coming up with a strategic document through an evidence-based kind of approach. So at that time, we surveyed the baselines and understand where we were at that time. And that are the targets that we are going to be passing through in the next slides. From the Lancet Commission indicators, so you know that those are the baseline indicators. So we think that at least 90% of people should be having access to care, especially essential surgical care, into our walk. So not drive. So we can go from your home to the nearest facility able to give you essential surgery in 2 hours. So we should be having at least 20 SRO, it means surgical anesthesia and obstetric providers. We should be having at least 20 of them for 100,000 population. Okay. So we think that if we can do 5,000 surgical procedures per 1,000 population is also a good indicator as far as surgical volume is concerned. The reporting of perioperative mortality rates should be reported 100%. So impoverishing expenditure should be avoided in 100% of the population, as well as the catastrophic expenditure. So those are the indicators of the Lancet Commission. And each country was requested to look into and see where they were in terms of meeting that. So this is Rwanda when we surveyed this some time back. And the only indicator which was ticked to be compliant was this one, the first one, the 2-hour access. So Rwanda has a very beautiful network of hospitals, so that everywhere where you are, a very good road network, you can go to the nearest hospital in less than 2 hours. The question is, if you get there, do you have access to surgical care? Do you afford it? Is there available? That kind of questions. So that's the purpose why NSOP was developed, to try to meet all the other indicators. So by meeting all the other indicators, if you look it well and analyze what was found at that time, you find that all the major domains in the health systems were to be improved in Rwanda. So we passed from infrastructure to service delivery, workforce, information management, and research. This is a big component of health system strengthening, financing, and governance. So there were issues around. The strategies laid out by the NSOP in those different major domains were highlighted as follows. So if we talk about infrastructure, we were supposing to improve the connectivity and be able to consistently supply water to theaters and hospitals, including the internet coverage, and be sure that the electricity supply is stable, so that the complex equipment that we'll be importing and displaying here and there are secured. So there are a number of action strategies that were proposed in this domain. So please go through and read it to be sure that we have covered everything. When you go
Recording in progress
to service delivery, you will see that we thought that priorities should be to redistribute the SAO strategically. So putting there some strategic hospitals and equip them and staff them so that we go progressively, and other strategies which are highlighted in this document. In terms of workforce, and I think this is where I'm going to articulate more because it is my area of play. So the targeted workforce, as you saw, the number were still limited. Maybe I will show it in the next slides, where our SAO density was around 1, and the target was 20, and there was a huge gap. So not only for surgery, but also for others. And that's why we have the panel today, where we're going to discuss how we're going to leverage and meet the targets together. But in terms of surgery, we have been requested to train specialists and subspecialists in a number of surgical specialties, including plastic and reconstructive that we are discussing today. Infrastructure, information management and research, finance and governance. So there are also a number of targets that we should be looking into, and maybe tomorrow in our breakout sessions, we are going to tackle them into details and see what was planned and to be achieved for these coming 2 years. Where are we in meeting them? So, that being said, those were basically summarizing what is written in this strategic document. But I'm going to pass through a number of challenges that we should be brainstorming about and see how we tackle them. So one of the issues is about the definitions. So SAO definition that we have in the Lancet Commission may be different from our definition of surgical anesthesia and the obstetric provider. Because there, they only consider those who are fully trained and accredited as surgeons, as anesthesiologists, or as obstetricians. But we know that in Rwanda and other developing countries, many people can be contributing to this task. So we have like trained non-surgeon physician who may offer some surgical procedures. And we know that many GPs can do C-sections and other surgical procedures. So we have non-physician anesthetists who are doing a lot and a big job in this country, and hence they are not counted for in the NSOP when we discuss the SO density. And we have others who are contributing really to this. So we may have to define a little bit differently what we call SO, or surgical anesthesia or obstetric provider in Rwanda. If we do so, by counting all the stakeholders, the players in this, we may pass from 1 to 8. Still, we are so below the number, because remember, the target should be 20. So we are around 1 when we only count those who are fully trained and accredited. If we go to include all the other key players, in that we can be around 8. So we think that the intensive training, especially for pediatric cases and the complicated emergencies, are not taken into consideration here. And we think to add another layer where we go for subspecialties and other high, not only high volume by complex kind of procedures. So how do we capture that and how do we care for it? So if I have to conclude, because I given a few minutes to talk about this. So Rwanda developed its own NSOP some time back. This is a comprehensive program to address vast deficit in surgical care. So access to safe surgery and anesthesia is among the key priorities of the country in order to achieve the universal health coverage. So for those who are joining today and those online, so please know that Rwanda is an excellent partner with whom to institutionalize and operationalize comprehensive surgical care. So I think this is my last slide. And just before we go, to show that, and I'm going to read this. It's a quote from the NSOP introductory remarks by the Honorable Minister Diana Gashumba, who was the Minister of Health at that time. So she said, the NSOP highlights where we are today and where we shall be in 2024. It reflects very concrete targets, detailed implementation plan with clear strategic indicators that shall allow a permanent monitoring of progress made. The smooth implementation of this plan calls upon all the stakeholders, including the providers, the partners, the insurers, local administration, as well as the population at large to ensure ownership and relevant support. I wish to convey my appreciation to all that have played an active role in the development of the plan and in turn pledge the full support of the Ministry of Health to ensure to its full implementation. So I thank you very much.
Thank you very much, Prof. Foster, on the overview of the National Surgical Obstetrics and Anesthesia Plan in Rwanda. So the next session is intended to talk about the implementation, talking about where are we meeting the targets as the Ministry of Health, head of the department planning. So I would love to take this opportunity to welcome again Professor Faustin on this session on implementation of the NSO.
Thank you, Simba. Actually, this was supposed to be a presentation from Dr. Parfait, the head of planning in the Ministry of Health. So he was supposed to be the talk online. Is the talk ready? So if the talk is not yet ready, and as we are a little bit behind the schedules, I will propose that we move to the next. Is online? Okay, cool. So please, the tech people, can you put Dr. Parfait online? While we are sorting out the technical issues and so that Dr. Parfait join us, Dr. Parfait is going to tell us how are we meeting the targets, and he is the one who is coordinating everything. So maybe there are things he knows that you don't know, but let's discuss what we know. So in our small areas, we do have in the room anesthesia people, nurses, surgeons. So anyone to take the mic and tell us in their professions and in their organizations, how are they meeting the targets? So if you don't tell me, I will call you, because you have to keep the online people busy and not just switching off the cameras. So, so let's go for Pauline. Banguti. Professor Banguti.
So sometimes they put the O in the middle of S and A. Sometimes they put the A in the middle of S and O. So you will see that for a good and convenient pronunciation, which goes with a little bit politics, it becomes the A is at the end. But if you see on the scientific papers published as indicators, the A is always at the middle. It speaks a lot because it's about complementarity. Anesthesia is in the middle because being the surgeons or the obstetricians all need that anesthesia. And when we are counting the numbers, it makes really stretching because the surgeon pulls on this side and the obstetricians pulls on the other side. And you can see them. Good example is in Seashika. We have two different blocks. So we have the block obstetrics and we have the block surgery. So if you are alone on duty as anesthesia, you are really stretched on the middle. So that push us to think about how can we train anesthesia to make them filling all those gaps. So where we are in Rwanda, another point I want to highlight is, I like how Faustin says, when they count at the beginning, they found it was, in Rwanda, it was 1 per 100,000. Then when they went around and say, oh, surgery is achieved by many different players, the same for anesthesia, so they jumped from 1 to 8. It's tricky. That jump is very tricky. So you are making equal the surgeon and the one helping him. They become 2. So
I like the debate. So let's maybe stop by there. And he's really paving the way of what will be the debate for these 2 days. And now that Dr. Parfait is ready to speak, so keep the Pauline's reflections somewhere. So we will come back to that. Thank you, Prof. So please, the IT people, you can help Dr. Parfait to join. Good morning, Doctor.
Morning. Can you hear me?
Yes, we do.
So yes. Thank you so much, Professor Faustin. Thank you so much, colleague, for the invitation. So shall I proceed with the presentation? I'll share with Arsene. I don't know if Arsene can put on the screen, or you want me to use my computer for the presentation.
Yes, you can share your screen. So they are also presenting
Okay. So thank you so much, Professor Faustin, and thank you so much, other colleagues. It's really a pleasure for us to invite us to this discussion, especially on how can we improve the surgical system. Of course, it goes with anesthesia, as Professor Paulin was saying. I think as by the agenda, I'll go straight to the points, share with you some progress on the development of NSOP, the National Surgical Obstetric Anesthesia Plan. This is the outline of the presentation. I'll talk about the introduction and then go to the progress on the NSOP and indicator, and then I'll give you some hints about how we are doing, and then come up with the conclusion depending on the challenge that we'll be seeing throughout the slides. So as As an introduction, we all know the burden of surgical diseases. This has been documented by the Lancet Commission of the Global Surgery, and there are some estimation around the world, 5 billion lives without access to safe surgery and affordable surgery. And also around 143 million procedure to fill, but still unmet needs in terms of surgery. And also limited investment in terms of surgery and also anesthesia and to enhance socioeconomic growth. So I would like to emphasize the key message from this slide. It's about surgery, but which is safe, it's affordable, but also surgery which is also is safe, is affordable, but also quality in terms of service provided. So the vision of this Lancet has been introduced. It was about to ensure that if can have universal access to safe, affordable surgery, and also anesthesia care when they need it. So going to the indicator for the 9 SOP, there's been a lot of discussion before up to the issue of issuance of the SDGs in country committed to the universal health coverage. In real term, universal coverage is about access to quality services, equity, but also some financial protection. And then there have been a lot of discussion when they have been online with the SDGs around 2012. The discussion has started, and different experts came together and discussed up to the 2015. After 3 years of discussion, they came up with the 6 indicator about strengthening surgical system around the world. And the team, the Lancet Commission for Global Surgery, has set some targets up to 2030. You see the 6 indicator about access, ensure that at least people are accessing surgery and anesthesia within 3 hours, and also increasing the workforce in terms of people are providing surgery and anesthesia and obstetric, with the target of at least having 20 surgical anesthesia and obstetric provider per 1,000 population, increasing surgical volume, which is a third indicator, tracking the perioperative mortality rates, and ensure that country are tracking more than are tracking fully 100% the post-operative mortality, but also tracking the impoverishment expenditure and the catastrophic expenditure. People are 100% protected for impoverishment when access surgical services, but also protected for any catastrophic expenditure. So you can see the 6 indicators goes in line with the investors coverage principle about financial protection, access, and also equity. So from there, there's been a lot of advocacy up to the time that WHO adopted one of the resolution in 2015. They adopted the resolution how country can strengthen emergency and essential surgical care and anesthesia as a component of universal coverage. The resolution has been adopted a couple of countries, including ours. Rwanda also was part of the country that was adopted. That's why we have been directed to develop the national surgical and obstetrical plan. So we conducted some baseline assessment, also doing our plan, on the draft our plan. This is how it looks like. You see the baseline 100%, the access 8.03 for the SAO, 786 for surgical volume, 76.2 for post-operative mortality rate, 90% protection from impoverishment, and also 89% of the catastrophic expenditure. So the National Surgical Obstetrical Plan has been developed according to the 6 building, I would say, indicators. And then we developed some key strategic intervention based on the WHO, building blocks. So you can see here we put the infrastructure, the service delivery, the information system, the finance, the governance, but also the overall costing of the plan. So for the infrastructure, we focus especially with the resolution of strengthening access to surgical care, surgical and anesthesia care. You see here in the infrastructure, water connectivity, delivery of oxygen, optimization of the equipment in the operative theater, service delivery, the distribution of the workforce, providing new services, the referral system, the standardization of surgical delivery across the health system pyramid, the workforce, increasing the number on the production, but also continue to build the capacity through continuous medical education or CPD, continual professional development. On the information system, strengthening data system to capture what is being done so you can measure progress on the implementation of our plan, and also address issues throughout the course of the implementation. The finance, see how they can, a lot of investment in terms of finance, to see how we can reduce this, the risk of people falling in impoverishment or catastrophic expenditure when they're seeking surgical services. The governance is about the structure, how role and responsibility of stakeholders, partnership around the implementation of the NSOP. And then we costed the activity by activity, and we came up with $70 million for the NSOP, which will, for the next 7 years that we developed at that time to 2018. So this is the progress of what we have so far. You can see according to the 6 indicators. Surgical volume, you see that it has increased throughout the year. We've been capturing, also reported every year, so we can make sure that we can discuss this. NSOP continue to be on the table, on the loop, or the health system strengthening to ensure that we are really tracking the progress. Perioperative mortality from the baseline, we are now capturing the perioperative mortality rates. That was the tracking. What also I have put on the test, the status that we have so far. We see that the slightly decreasing, even though there is no, I can say that there are no significant changes in terms of perioperative mortality. So the SAO, the number providing, at that time we were still discussing the definition. We came up with some definition, and we keep discussing with the stakeholders, and that's the setup that we have for the SAO. I had some discussion from the previous steering committee with the NSOP, with anesthesia representative, especially Professor Colin. Maybe we can continue the same discussion going forward. So the catastrophe expenditure, these are more outcome indicators. We are planning to do some calculation also throughout the MTR, midterm review of the NSOP, that we are going to conduct very soon. So this is the picture of the surgical procedure that we perform. That should give you a hint how it goes. You can see that the volume of surgical volume keep increasing to show us that there is demand outside. So it's up to us to make sure that we can supply if the demand is there. So the distribution, you see the OB/GYN take the big share of the cake here, and the other going forward orthopedic because of the trauma. So the key message here, we see that non-obstetrical, because if you take only the non-obstetrical surgical volume, you see that orthopedic take also the big share. So most of this is trauma. So we need to address the issue of trauma. but we'll continue to do more prevention in terms of this. So, and the rest you can see here. Of course, it gives us another message that we can see what are the system strengthening components we need to improve to ensure that these unmet needs that we have been discussing, because it's a global burden of surgical burden we have seen for the previous in the previous slide of the introduction. We have seen that there is an unmet need, so we need to unlock issues that are in the health system strengthening to ensure that people can get services. More specifically, as we are here for the conference of plastic surgery. So plastic surgery, the demand is there. I won't say that the demand is not here, but I anticipate that maybe some issue of finance. That's why we've been working with them, especially recently, to conclude with at least including some more procedure on the benefit package to be paid by the insurance. So we can see that the volume can increase, but also in terms of access. So this is a distribution that show you which hospitals be carrying a lot of burden of surgical volume. You see CHK taking the big share here, it's number one. And also you see that some other hospitals that are also not doing well. So the key message here from this slide is about showing that are we optimizing the opportunity to make surgical volume being carried out or performed in this other hospital. And I think that's quite of the thing that we will still continue debate to discuss with the surgical and anesthesia community or professional, but make sure that some of this hospital, we see that in terms of equipment, human resource, they're quite somehow equipped to ensure that can also perform some major surgery, and also understanding the way we can improve the referral system so that there won't be imbalances of some hospital carrying out the big burden of the surgical volume. So this is the average number of the procedures. See that some of the other are following up. So as a conclusion that I've been just taking through quickly in this presentation, we have seen that there is still, throughout the implementation, there is still a lot to do throughout the strategic intervention of the NESOP that I presented before the previous slide. So some of them we have already started working on them. That's why I've showed the way forward. Some of them will be implementing, and also the rest of the things that we need to address going forward. So we have this last year, we have reviewing the reporting form of the referral hospital. Of course, surgery is part of the referral hospital services. So to ensure we can capture, so we discussed that we have, but also the baseline that we conducted, we've seen that some of the data might be not being fully reported. So that's why we sat together with professionals, including the surgeons, to ensure that we can capture more and see in the reporting form, so it can also inform us going forward with the implementation. But more specifically, to include the element of data quality for better decision making going forward. Where we have also been mobilizing resources. Some of the hospitals have been supported in terms of equipment, in terms of workforce, to ensure that they can increase the volume. So I won't be going into the detail to mention them, but these are the things that we are continuing. The work is still continuous work in progress. We also, for the SRO, increasing the SRO provider, we all know that producing surgeon on anesthesia or these SRO providers, it takes long, but also, for the production, we don't have so many people joining this this specialty, because somehow tiresome and people embracing like internal medicine or pediatric surgery, pediatrics and other specialty. So that's why we have been working on the policy level. Recently, I think last year, the Ministry of Health has issuing the instruction on the credentialing and the privileging of professional, because the baseline, also the data that we have been analyzing for the past year, when we started developing the NSOP, we see that those are some people, if they're well trained, credentialed, privileged, they can carry out some bellwether procedures been shown by the evidence through WHO guidelines. These bellwether procedure are just mentioning, let's say, for example, emergency laparotomies, C-section, external, open fracture for external fixation. All of the things that can be done by other people are not fully trained as surgeons. So we have been working with professionals to develop this ministerial instruction. Ministerial has been issued. We are now developing the criteria of the selection. Selection criteria. Recently, it will be also issued, and we start the implementation, and also working hand in hand with professional society and professional council to ensure that we can also increase the workforce, the people who can do the surgical service, provide surgical services, especially this bellwether procedure. This can help us to improve even the timely access to surgery, surgical services, but also increase these providers' density that we are aiming at. Since you know that the target is up to 2030, we have to reach at least 20 per 1,000 population, which is quite a big, a lot of effort, but also very ambitious. So we need to find another way of doing things as been documented by the evidence. So the other thing that we are going to conduct is the midterm review of NSOP to assess the progress that has been made so far. And then from there, we'll be able to assess and highlight the gaps and came up with some recommendation. How can you improve the surgical and anesthesia systems also to ensure that people can continue to access services, surgical services. So we have already started with some colleagues. The discussion last week, we had a meeting with some colleagues to see how we can conduct the MTR, and then definitely we'll keep engaging the steering committee of NSOP going forward to ensure we came up with sound recommendation, but also very important things is it's having the recommendation somehow feasible, also implementable, and having kind of mutual accountability. So the other thing we are working on is keep reviewing the benefit package or the tariff to ensure we can continue including more surgical services at the referral hospital, at the tertiary level, to ensure that people can continue to access affordable and safe surgery, safe and affordable surgical anesthesia, so that we can reduce this out-of-pocket payment, which make people falling in catastrophic expenditure, but also in later falling in impoverishment. So, colleague, this is the few slides I just prepared to trigger the discussion about the NSOP, going through what we have been doing, all of us, because it's our plan, it's our strategies. We need also to update you, and then also continue to work with hand in hand to ensure that access to surgical anesthesia services can be more feasible, but also practical in our settings. So thank you so much for your kind attention.
Thank you, Dr. Parfait. So thank you so much. So we know how busy you are, and that you are out of the country in an official mission, and making time to join us today. It's really a privilege. Thank you very much. So for highlighting the progress so far made, and that we found there is a good improvement from the time we surveyed. And now we are heading to a midterm review that we are all looking at. So I had colleagues from Operation Smile and other stakeholders saying that they are willing to be part of that. Please contact them so that you plan together. We know that a number of initiatives are ongoing from the ministry, the university, and the other stakeholders. So we'll be happy to join you to next specific meeting on NSOP. So I like the idea of looking into task sharing. Maybe the whole concept of task shifting may be discussed, but we can share the task. So I don't see that it is like an exclusive club where there is something which should be only done by one person. So we have to also to find ways to discuss around that. And I'm happy that now the new tariff is out, and many procedures that we do in plastic and reconstructive surgery are on. So thank you very much. I will not be coming again in your office. So thank you. So now I hand over to the moderator so that we are a little bit late. So please hurry up so that our colleagues online do not leave before they speak.
Thank you very much. Thank you, Deje, for the nice talk. So, as Professor has reminded us, we are lagging behind in time, so I would like to remind the speakers to try to keep time. And as a reminder that this symposium is an in-house and also online, so we're blending two. So our generous and kind audience online would like to remind you that if you have any comment or question, please, you're welcome to throw in any question or comment online, where we will follow it up and share it with everyone else. So, we're moving forward with the next speaker. We're going to welcome, she's also going to present virtually. It's Professor Gosman Amanda. She's the chief of the Division of Plastic Surgery at the UC San Diego Health. And she also directs the Plastic Surgery Residence Program. And also she's the director of Pediatric and Craniofacial Division. She's a professor at the Department of Surgery, where she carries out research on craniofacial surgery, cleft lip and palate, plastic surgery outcomes, telemedicine, and international health. So without adding further ado, I'd like to welcome Professor Amanda.
Thank you very much. Can you hear me okay?
Yes, we can hear you.
Wonderful. Let me share my screen. All right. Well, thank you very, very much for this kind invitation. It's really an honor to participate in this conference, and truly an inspiring example of capacity building going on in Rwanda in the area of plastic surgery. So I was tasked to talk about the power of collaboration, and I'm going to speak today about an initiative that we've developed over the last several years to try to really harness some of the multiple organizations around the world to come up with a way to really increase capacity in plastic surgery. So the plastic surgery workforce, as has been, described eloquently by the speakers and organizers of this conference. I'm sorry, somebody's drawing on there. Is really something that is sometimes difficult to understand for a lot of health systems in any part of the world. And building a plastic surgery workforce really relies on the stakeholders understanding the value of plastic surgery. And I'm not sure how to get rid of that annotation, but I'll just leave it there. The stakeholders that are brought together initially to really define what the need is for plastic surgery is something that really takes a lot of insight. I think that as a specialty, we're frequently misunderstood, and understanding the value of plastic surgery to a health system really requires looking at our collaborative value as we interface with trauma, as we interface with oncologic services, and how really in many aspects of healthcare, we have a role of elevating overall care, quality of life, and surgical outcomes, whether it comes from trauma or dealing with other aspects of care. Somebody's drawing on the screen. In the Ministry of Health, let me just try to clear this annotation. I don't know if it's possible to do. There you go. Okay. The Ministry of Health, I really want to commend in Rwanda for really identifying the value of plastic surgery. I think Rwanda is truly unique in that sense because it has been challenging for all of us to really understand how we contribute. Right. Sorry, seems to be a little, I'm not sure how to have that stop. Arson, I don't know if there's a way to make that go away. But the surgeons in particular are ones that, really, I think are the true stakeholders as well as their patients and identifying, where the role of plastic surgery is. And although the immediate need is usually identified as in the areas of burns and trauma, that there's also like an incredible need for integrating the full scope of plastic surgery, and that includes reconstruction after cancer. And I know that in Rwanda, you guys have made tremendous progress in expanding your oncologic services in so many aspects of your NSOAP, and that it has really opened up the role for plastic surgery. It kind of speaks to how evolved the progress is that you guys have made in your work thus far. I think that ultimately, the story that I want to tell is one really of educators, and that's really the basis of this collaboration. We have, many of us have participated in many different collaborations throughout their ventures in global surgery, but there is now quite a large body of educators that are representing multiple academic institutions that not only have their own skills to leverage, but also have incredible value in terms of being able to share resources. The academic institutions are kind of like the monolithic structures that can bring into resource limited areas some of the capacity to do research, to really understand what our patients need for outcomes that are going to be optimal and the goals of collaboration. The NGOs such as Operation Smile, who've clearly done an exceptional job building and collaborating in the training programs in Rwanda for plastic surgery, are more like the speedboat that are able to maneuver through various barriers that are difficult for academic institutions, large societies and ministries and governments to navigate, and are essential partners in many of these ventures. And we look at a way to try to bring all of these organizations under an umbrella that can really harness the different skills, the resources of large organizations, and the maneuverability of the NGOs to try to address the issues. Through a lot of research to try to determine what is really the best approach to building capacity, I think that professional societies have a lot to offer, as they can serve as a house for overseeing much of our surgical education, as well as can you hear me? A lot of stuff going on.
Yes, we do hear you, Prof. Yes, go on.
Okay. There's somebody drawing on the screen, but hopefully that's not terribly distracting. But the professional societies is really kind of the approach that I'm going to talk about today in terms of what we've tried to do for optimal leveraging of educational resources. So I think in the COVID era, more than ever, the educational resources that have transitioned into a virtual space have really made the world a lot smaller. We have participated in a lot of virtual learning prior to COVID, but it wasn't widely adopted. And you know, the necessity of having to transition to that space has really made the world much smaller. And leveraging technology and innovation is something that I think will continue to be at the forefront of collaboration and of capacity building as we go forward. Today, I'm going to talk about an effort that was put forth by the American Society of Plastic Surgeons, which for plastic surgeons is really the largest organization in the world. And it's not only representing the majority of board certified plastic surgeons in the US, but also has a large network of MOU affiliated countries all over the world and over 8,000 surgeons that really represent an opportunity for multi-directional learning. And I think that's what's really also critical about plastic surgery. Unlike